on this computer. And thank you all for joining us and me on this Saturday, the day after the CDC officially endorsed the third dose of the mRNA vaccine for the immune compromised. I backgrounds named this presentation a backslide, and I'll tell you why. So as many of you know, and you all were vaccinated through my office with the Moderna, vaccine's no longer a scarce resource, but it's still a difficult system to navigate. And it's important to keep this in mind as we try to deliver vaccine to you, or as you may have questions about how how is this going to work going forward? As you learned in prior talks that I've given you, the CDC allocates vaccine to California, and I had signed up in November, December, and got all the registration in process. And this is still pretty much the same. The county will allocate vaccine based on supply. Now, to let you know, I already anticipated this day coming 2 weeks ago, had placed my order, and I have vaccine in the refrigerator. So just to reassure everyone, this is the quagmire I have to go through. But just know that we, try. The state of California created this system for after the fact, that when you received your vaccine, they created the digital COVID vaccine record. For everyone's information, all of the vaccine administered in my office prior to mid-February was manually decoded. I was up until 1 a.m. creating these computer codes of your vaccine records and then sending them to the San Diego Immune Registry. This is before all of these platforms were in place. And then San Diego Immune Registry was sending those information codes to the state of California. Subsequently, we were able to make my electronic record system bypass a little of that and directly connect with the state of California. Now, for this digital vaccine record to work, you need to have the name, date of birth, middle initial, any spacing, any cell phone numbers perfectly match with what the state of California has you under. So if you received a vaccine from somewhere else and then gave me a different piece of information, it may not match. The second thing is that the information given from San Diego is separate from how other cities and communities in California work. So there is some glitches there. San Diego has reported everything to the state, but the state's integrating all that information. So if anybody's having trouble with their digital records, let us know. We can check in our system, see if we can bypass it, send it directly. But there is still a lot of glitches at the state level that they're still working through. But this is important to know that there is this background visibility of your immunizations because they will know that their dose has been administered. So let's talk about what's going on right now. This is a situation report. So this was from a CDC meeting 2 weekends ago, and then there's another one at noon today that it's globally attended. And this was an amazing meeting. This is a gentleman who is tracking all of this at the CDC, and he is pictured on the right. Since July 6th to July 28th, we've gone from kind of predominantly low level COVID to red throughout our state. And I think that it's going to be even higher across the board if we looked at this weekend. If we if we're examining this weekend, but this was from July 28th. What about California? This is something I showed you when we were near in our peak. In February, we were at our low in terms of ICU beds. We were at our peak in terms of incidents. And then we started increasing our bed capacity. Here we are now as of yesterday. This was February. We are starting to see an increase in hospitalizations and a decrease in ICU beds. So that's important to keep in mind. We still have enough, but if we look that this is when we really didn't have very many, we're heading in that direction. If we look at yesterday's data, we have over almost 4 million cases of COVID in our state, and it's rising at 24.6 cases per 100,000. When we were in our surge in February, we were at 25 cases per 100,000. So we were, even though we're all unmasked or folks are unmasked, we are still having some similar numbers and trends. Deaths, I would argue it may not be the appropriate metric now. I mean, deaths are very important, but now that we have a highly vaccinated population, morbidity, getting COVID and surviving the ICU is not a benign event. Our test positivity has trended downward a little bit. It was on the upswing, but 6.6% of tests are positive. Those are numbers that are considered to represent widespread incidence of COVID, which is reflected by yesterday's San Diego map. We are all in the purple transmission zone, the 6.6% of testing positivity by the state. We are at 8%, maybe even a little bit higher. So why is this happening? We got unmasked in June 15th, despite nearly 40% of our population was unvaccinated. Unvaccinated people remain unmasked. CDC did not appreciate the honor system in human behavior. They had said, well, everybody can be unmasked if you're vaccinated, and the unvaccinated should wear a mask. Well, that created a lot of stigma, and the vaccinated who wore a mask, like me, felt like, I remember going into Walgreens and people were staring with like darts, thinking that I was unvaccinated. I could just tell there was this tension in their face. And I, as you all know, was vaccinated Christmas Eve. So I think that human behavior factor was not appreciated fully. Arrival of the Delta variant, I'll show you a little bit in terms of the phylogenetics and the pathogenesis of that. There's a lack of surveillance after unmasking. Not only did we unmask, they stopped doing the sequencing because the labs, the state was just taking a breather. They were overwhelmed, and they said, we don't need to sequence. We'll only sequence cases in the ICU. And then travel restrictions were loosened. So I think it was and then 4th of July. So I think we had this perfect kind of lineup for why we're seeing the case rates go up. And then let's talk about the Delta variant. So we used to be worried about the UK variant, which is considered the Alpha, the B117. This we talked about in a prior presentation. So the coronavirus right here with all the spikes around it is, that's why it's called the coronavirus, because it's got this crown of spikes, is highly variable in terms of its spike protein mutations. Now we are learning it is interesting in how it is up mutating. It is outsmarting our our immune systems. And as long as there is a host for it to land in, attach to our cells, spit out its little machinery, use us to duplicate, which is what all viruses do, and then creates more virus. And then that's how it is shed and spread. So this is the spike protein. This is our host cell attaching it, receiving this virus into our bodies. So when these are little attachment spots, or this is called the epitope, and this is the entire spike. The Pfizer vaccine covers this whole spike. The Moderna covers the epitope for the attachment. So the B117 had 3 little deletions or mutations in this. So it just kind of changed the modeling or the shape of the spike. The B16.1617.2, which is called the Delta variant, has multiple mutations. Actually, one of the mutations, the L452R, was something we all have already experienced during our surge. This is considered part of the California variant, which we know was 20% more transmissible. Now, this one, I don't know if you've all heard about the Delta Plus. The Delta Plus is all these different other variants within the Delta. So because of their long kind of mutational numbers, they're just calling it AY.1, AY.2, AY.3, AY3.1, or maybe I forgot the dot. Currently, 90% of sequenced variants in California are Delta, and 9% as of last week are the AY.3. Here is from the CDC in terms of the variants and what is circulating right now as of August 7th. It's important to keep in mind that this data is about 3 weeks, 2 to 3 weeks behind. So what we're seeing last week when we swabbed somebody, diagnosed them with COVID, and in breakthrough vaccinated individuals, that information goes to the county, then goes to the state, then goes to the CDC. So there's this lag. And so what they're seeing in currently is pretty much correlating with what California is seeing. So we're starting to see some Delta Plus, which we know increases, it has a higher transmissibility. We don't know in terms of its morbidity and mortality. So the Delta variant is more contagious than the prior strains. And we're considering the first COVID or coronavirus, the wild type, and the others are all strains. And it may cause 2 times as many infections. And this is from the CDC. And it still is proving that it does protect us from hospitalization, severe infections, and death. 90% of current hospitalizations are of unvaccinated individuals. We are seeing some breakthrough double vaccinateds in the hospital, and they tend to be the immune compromised. And that's why the CDC focused on their recommendation yesterday. I'd like to stop share right now and just show you this website. And this is the kind of the phylogenetic pathway of the Delta variant. And this is on GISAID, and you can find a ton of global information on here. And this is just, if you'll look at the dates to the left here and look at these different, this is all Delta right here, B1617.2. And just look at this is now in March, as we go forward, this is how the virus has spread to arrive to us. And I think this visual is very impactful because we need to keep in mind this virus doesn't know how to swim. And what you're looking at here is it looks like Europe seems to be our transmission portal. Also, interestingly, we're seeing a little bit more green here in the United States, unlike what's being isolated in India. So some mutations are occurring in Europe that may be transmitted here, or we're creating our own mutation. So I thought this was important for you to see. So let's talk about vaccine efficacy against the Alpha and Delta. Alpha was what we were really worried about, the UK variant earlier on. And that had contributed to our surges, although we had the California variant as well, and compared with the Delta variant. So we have to remember England and the UK had AstraZeneca vaccine and Pfizer, and they had spaced out their immunization windows and range for the second shot. Israel predominantly had the Pfizer vaccine. Canada's got a mix. And here you can tell which vaccines were present. And so I think we have to look at what's happening in Canada and what's happened in Israel to get an idea of what's going to happen with our vaccine. And it looks like the Pfizer vaccine or the Pfizer BioNTech has a decrease in efficacy by about 36% against Delta. And in Israel, and I'll show you some of the information there, and I was talking to some docs over there a couple of weeks ago, and they were seeing an increase in ICU admissions for double vaccinated. And that's why that population of 9 million people who all went unmasked, lifted travel restrictions, are now replacing all of those restrictions in place. And they were one of the first to administer a third dose to age over 60. In Canada, it looks like things are still okay, although there seems to be a little bit of waning immunity for Moderna. They've got a different experience with the Pfizer. Against hospital admission, all of the vaccines are still protective. And that's important to keep in mind. And this is an important piece of information that you guys might have read about. I know I think Thursday's Wall Street Journal, this data point lifted Moderna's stock prices a little. But we still are protected against hospital admission and death. What about Lambda? C.37 present circulating in Peru and South America. Don't know enough about this. It is believed to be less infectious than the Delta variant, but more infectious than the wild type. We don't know in terms of its genetic profile, how it's going to affect our community transmission, severity of symptoms, or if vaccine resistance is going to occur, whether there's vaccine escape or monoclonal antibody efficacy. In lab studies, it does seem like it may not be protective in by the vaccine, but so far we're not seeing it percolate through here. So what does it mean to be vaccinated? And I want to keep this visual in the corner in mind because we just have to realize that we don't know who's breathing what on us. I have to admit that this last year has been wonderful without seeing flu and some other respiratory illnesses. But when the unmasking started, we saw not only COVID, but parainfluenza, human rhinovirus, RSV, and a whole host of other viruses. Some we haven't even characterized yet. But the variants are easier to transmit, and they do tend to attach to our mucosa a little bit better. Respiratory droplet and airborne transmission are still our number one methods of receiving this virus or any virus. And the current vaccines do help reduce this transmission. So let's look at Israel, and what about the third dose? So in Israel, they noted a jump in cases of severe illness at the beginning of August. And for them, in a population of 9,400,000 cases, with 240 being vaccinated, ending up in the hospital, was a red flag for them. And they noted people over the age of 50 accounted for more of the severe cases. And this is last week's headlines. So I kind of watched, so the ACIP is an advisory body of the CDC that makes recommendations. The FDA approves a vaccine based on the application a company submits for use of its product. They don't act before that conversation with those companies. So that's important to know, because when the monoclonals weren't being expanded for all of you, and I was emailing Washington, DC going, and we then emailed all the companies to get them to expand that, to put in the application so that the FDA could then approve it for expanded use, so that then the regulatory bodies like the CDC and these committees could then say, yes, these people should get it and it would be safe. If we act outside of that, the protections that are in place for vaccine-associated adverse effects would not apply. That means if someone has a rare side effect or a disability due to the vaccine, then you won't be compensated. So that's just one caveat to all the recommendations. So everything that is set in place for protection of the public. So I witnessed this vote online yesterday because they live streamed this. And they said an additional dose of Pfizer BioNTech in age over 12 or the Moderna in age over 18 is recommended following a primary series in immune-compromised people. Now, what they're calling this is not a booster. So we need to look at the semantics. What they're saying is that immune-compromised people require 3 shots or 3 doses to achieve some level of protection. And it is not going to be as high as the data, as the numbers I showed you previously. But so this is now considered a primary series in immune-compromised people. And the rationale behind that is that, and Keith Talbot is part of that committee, and she presented to us a couple weeks ago. So we kind of saw this coming down the pipeline. And she's an ID doc at Vanderbilt in Tennessee. The percent of subjects with antibody response after 2 messenger RNA vaccine, and this is only just 63 patients after with immune compromising conditions. This is the healthy controls, but you see that there's a large number of people here who only achieved 40 to 60% immunity. And these folks were also coming into the hospital a little bit more. But this is the group that's really worrisome because after 2 doses, there are many who have just 0 antibody response. And so this is the primary focus for the group that is being considered for the third dose in their series. Also, these hematologic cancers, and they're actually added in just any cancer because you're undergoing chemotherapy. So here's the data regarding the third mRNA vaccine dose in immune suppressed people, and kind of a compilation of their the sample size. And some of the responses after the second dose were quite low. And then even after the third dose, only 33 to 50% developed an antibody response. So it's important to keep this in mind, that even after the third dose for an immune compromised individual, we're only at 33 to 50%, but that's better than zero. So therefore, this is the guideline on who should receive the third dose in the series for completion of their vaccine regimen. Anybody receiving active treatment for a solid tumor or blood cancer, anyone taking immune suppressive medications after organ transplant, and we know there's a few out there in this audience, within 2 years of receiving CAR T therapy or stem cell transplant, any who have primary immune deficiencies due to a genetic disorder that prevent the immune system from working properly, and anyone with advanced or untreated HIV. Treated and controlled HIV doesn't count. Taking high dose steroids, the equivalent of prednisone, any alkylating agents, antimetabolites, chemotherapy, TNF blockers, and we have so many people on different types of immune modulating or immune suppressing biologics. So this is a big category right here. And then this one, chronic renal disease dialysis patients. As you saw, dialysis patients did well here, but their immune function did drop and wane. Dialysis patients and living without a spleen. So that is the list they've provided us. This is from the CDC website I pulled this morning. Other factors to consider is just the general level of immune competence, the disease severity in a person, clinical stability, frailty, comorbidities. And if we foresee that an individual will need immune suppressive therapy. So if we're in the workup and think that there's a malignancy that's likely to be diagnosed, probably I'd want to give the third dose now so that in 2 weeks they can start chemotherapy or other treatments, whatever we need to do, or a autoimmune or rheumatologic condition. This is nice wording here. A patient's clinical team is best positioned to determine the degree of immune compromise and appropriate timing of vaccination. So I was pleased to see this. Now we're going to get more instruction in a couple of hours how to navigate this list. Let's talk about some complications of the vaccine. They are rare. Most is well tolerated. There's, of course, the local sore arm, fever, muscle soreness, but there are these reports of myocarditis or pericarditis after COVID-19 vaccine. JAMA just published some information, and the VAERS has received 1,250 reports, but 730 have been confirmed. Most are in age under 30, and it happens after Pfizer as well as Moderna. And I have to admit that I have seen one potential case. So it may happen. Most are well tolerated, and only 8 of the 730, I think, or 80 were hospitalized, but they were discharged. And they do recover. There's anaphylaxis after a COVID vaccine. It's rare, and 2.2 to 5 per million of the vaccinated in our country have had anaphylaxis after a COVID vaccine. Guillain-Barré syndrome, that is something where we see a peripheral neuropathy and paralysis, ascending paralysis. It has been known to occur with any viral vaccine. We see it annually with some flu vaccines. And it has been reported more with the Johnson & Johnson or the Janssen vaccine. To date, there have been 2 confirmed cases of what we call thrombosis and thrombocytopenia following the messenger RNA Moderna that have been reported out of 335 million doses of the messenger RNA vaccine. The clotting side effect of the vaccine is predominantly with the AstraZeneca and the Janssen vaccine. So, as you all know, anybody with any of these conditions are at high risk for COVID, and they were a priority for getting immunized early, as most everyone in my practice was immunized in the month of January. So everyone's 7 months out, January, February, so 6 months out from completing their vaccine doses. Not all of you have all of these conditions or anything, but this is just a high risk list. And if we are at high risk, we should continue to protect ourselves is basically what I'm trying to say. How long does immunity last following the messenger RNA vaccine? Well, the best current data is from Israel's experience, because their vaccine administration for the Pfizer was similar. And this is now from Pfizer's own research and press release. I don't like to practice medicine by company press releases, but they stated that they appear to wane 6% per month. I would look at us healthcare workers as the barometer for this waning immunity. And I personally have received the Pfizer because that was the first shot offered to me last December. So I do share that concern, but I feel confident that I'm at least protected from hospitalization and death. Moderna still remains at about 80% protective right now, and we just don't know how it's going to behave. I think we'll need to look at Canada, but I think we are on the front line and we are the data points for answering this question. And that it does make me uncomfortable. And so we do know vaccines protect us from severe disease, which is great after having lived a year of having my funeral plans in order. But I would really think seriously how we go about our day, masking and unmasking ourselves, how long we stay with people that we don't know in indoor settings, and what our own personal underlying risks for developing disease and having complications is. So I'd like to backtrack a little. This was from a March presentation when we talked about the path forward. And they had stated you can gather indoors with unvaccinated people from one other household, like relatives who all live together without masks, unless any of those have underlying risk for severe illness. And I'm like, this is me adding those comments. What confusion was added? And then at that same time, refrain from quarantine and testing following a known exposure to COVID. So I think that kind of set up what we're facing now. And then the CDC also has not been real clear about their masking guidance. Why not just say, let's get masked up and everybody go out and do whatever you need to do. So it's important to know in infections in unvaccinated, vaccinated, and what would happen if you did get infected and being double vaccinated. And the CDC is watching healthcare personnel and essential workers. They get weekly swabs, and they've found 204 confirmed breakthrough cases. And then this is old data. And we have to realize Delta wasn't circulating at that time. So there were still some breakthrough, but everybody did well. Runny nose, congestion, some are feeling, a dry cough, but the vaccine breakthrough tend to get better faster than the unvaccinated population. So that's important. So until we know more about some of the questions I've posed to you, I would still remain masked, 6 feet at least, if not further apart, unmasked. There was a report in Texas of an outdoor picnic being a super spreader event. Some other outdoor events in Martha's Vineyard is seeing uptakes. And then also the one that started all of this was the one in Boston or in Massachusetts that showed that people who have been vaccinated can carry the same amount of virus and transmit as unvaccinated individuals. And still, good hygiene, protection for transmission of any disease. Wash hands is important. I'm getting lots of questions this week regarding surfaces, and that is less of a transmission risk unless we have, unless you like wipe something that's moist and then rub your nose. Can we travel? So nothing's changed in terms of yes, you can travel, but there are some countries that are at higher transmission, but it's no different than I think what we are living with right now. We'll need to get tested within 3 days of return to the United States. And sorry about that. And are airplanes safe and for how long? And that's something that I don't know the answer. We do know that vaccinated travelers, there was a study done of all arrivals in Qatar, and a very small percentage had disease. Well, now the Delta is changing this whole paradigm. So I think that's something that we need to keep an eye on. I was telling some folks last week, I think airplanes are safer than grocery stores because right now grocery stores have unmasked and airplanes enforce masking. I would consider duration on the plane. If someone's sick behind you or in front of you, those are all still standard recommendations, but I don't know how long airplanes will continue to be safe for travel. Predicted activity. So let's switch gears to the monoclonal antibody therapy. We really need to get the word out that early in the course, if you're at high risk or at any risk for hospitalization, we do have a treatment to offer. And it is casirivimab and devimab or sotrivimab, which this was just approved by the FDA 2 weeks ago. This checkbox should be a red X here. This combination has been removed from California just because it doesn't cover our California variant. So these are the two options. I have not seen anybody receive this yet. It's still so new. But the casirivimab and devimab is a monoclonal antibody. Just think about it as external antibodies that come in there and help stop the virus from multiplying. And the earlier you receive this product, we halt the progression of the virus doing damage to you. And folks have received it. We've been given this and ordering it for people at about 2 a week. It comes in an IV infusion. Sharp Coronado is able to do it, and there are county sites that are administering it. It also is in a subcutaneous injection form. It requires 4 shots for that, and that's kind of burdensome. But we do a 1 hour IV infusion. It's well tolerated, and people start to feel better within 48 hours, as long as you're early in the course. The later you are in receiving this, then it'll be a little bit prolonged. No one's been admitted to the hospital after receiving this product, which is important. So that means it does stop bad disease. So just, even though if you're not qualified for a third dose for your series, we still have options. And this is very reassuring. And so let's talk about kind of what the projections are. I know the Institute of Health metrics in Washington, people have kind of had discrepancies with, but they've been okay about their predictions. And they've got this tally of what they're thinking is going to happen for the rest of the year. And that's important for us to keep in mind as we contemplate going forward. So here we are right now, and today was yesterday when I made this slide. Worst case scenario is that we will have 750,000 deaths if we go at the current trajectory of mutations, unmasking, just things getting worse. If this is the way the current virus, so this is if there's mutations and other different scenarios. If this is just Delta, we'll hit 700,000 deaths, which is still not a pleasant thought. If we put the mask on, we can help, but we're back to flattening that curve. But we can help prevent death. And I think, that is very important. What does our future look like based on those predictions? I can't wait for this pill to come out. It's anticipated to be released in December, molnupiravir. It's like oseltamivir, which is Tamiflu. And it early on, it will stop the virus from duplication. And so whatever we can do to stop the virus. Interesting with the monoclonal antibody, and I just digress here, is if someone is high risk immune compromised, they have their third dose in, but they've been exposed to a family member with active COVID, say a 20-year-old healthy person, double vaccinated, but still brings home COVID, that individual that's at high risk is eligible to receive the monoclonal antibody and as what we call post-exposure prophylaxis. That was just approved 1 week ago. So right now we just don't have the protocols in place on how to get that person to that drug, but I think as physicians, we can order it and we can make that happen. Home test kits that are reliable. Right now, the home test kits are about 50% reliable. Antigen kits are also only about 58% if you're asymptomatic reliable. Continued distancing in airports and planes if we can. Sorry about that. Masking, and I put, let's get near 100% vaccination by medical professionals so the disease isn't transmitted to patients. We are seeing that in nursing homes, and we are having to boost with the post-exposure prophylaxis for some nursing home patients here in San Diego. Continued use of the monoclonal antibody to prevent hospitalizations of COVID positive. And again, I want to know if you've got runny nose, sore throat, congestion. We'll test you. We'll try to track it down and getting it early so that we can get treatments on board so hospitalizations are prevented and we can take care of you. So I'm ready. Vaccine arrived last week. I have a limited supply. I have to follow the CDC guidance so that if there's any adverse outcomes, folks are covered. What was interesting is this little caveat that these extra doses will be given on an honor system. So say this is for Walgreens, Rite Aid, uh, the public health systems that are these mass vaccination sites, or a patient can go there and say that they have a condition. No prescriptions or other kinds of clinical documentation will be required for a person to get a third dose. I'm waiting to see if there's going to be any change today based on the CDC Infectious Disease Society call. But as of yesterday, that's kind of the interpretation we received. And with that, we still do our usual what to expect after getting COVID and your vaccine checklist. So with that, I'm going to stop sharing and try to answer some of these questions. Do I have the Pfizer vaccine? Yes. I'm going to stop recording now so that we can speak candidly. So